Good evening, everyone. On behalf of Indian Academy of Pediatrics, Allergy and Applied Immunology chapter, it gives me immense pleasure to warmly welcome all of you to today's academic webinar on first 1000 days allergy development and prevention. The first 1000 days of life, that means from conception to the end of the second year, represent a critical window that shapes immune programming and long-term health outcomes. Emerging evidence has clearly shown that several early life interventions during this period can significantly influence the development and prevention of allergic diseases. Through today's deliberations, we aim to translate this evolving science into meaningful clinical practice for pediatricians across India. I am deeply honored to introduce first our chief guest, Professor M. Singarvelu sir, the President elect of Indian Academy of Pediatrics for 2026. Professor Singarvelu is a highly respected and visionary pediatrician with over 4 decades of experience in clinical care, academics, research, and leadership. He has served with distinction as Dean and Head of the Department of Pediatrics at Government Medical College, Tanzanwar, and Professor of Pediatrics at Vinayaka Mission Medical College. His immense contribution to pediatric education, mentorship of generations of students, and continued commitment to clinical excellence have made him a towering figure within the IAP fraternity. We are privileged to have his guidance and blessings for today's program. Sir, you are welcome, and I would like to request you to give your blessings to us, sir.
Thank you, sir. Thank you. Namaste. Good evening to all of you. The most dynamic academician come leader, chairperson of the very important chapter in IAP, the growing chapter and need of the hour for every pediatrician is allergy, which allergy and immunology going to be the future for general practitioners of pediatrics, where it is headed by Dr. Neeraj Gupta, and it was ably supported by immediate past president Kishan Mohan and Upin Reddy and the Walvekar treasurer and our scientific convener Sinchana Bhet and Narmada, and so many stalwarts are there in. And today, this is a very unique concept which is going to be moderated by none other than a very active academician in allergy, Dr. Nandana Bala. We are very happy to have our overseas faculty, Royal Robert Boyle sir. Welcome, sir, on behalf of our IAP. Roy sir, we welcome on behalf of IAP, on behalf of Allergy chapter. I take this as an immense honor privilege given to me to inaugurate this today's session as a president-elect of our prestigious world's second largest pediatric body in the world, next to American Academy of Pediatrics. I have seen, we as a pediatrician, we are already oriented to 1000 days concept. That is the day of conception up to 2 years regarding the nutrition. Nutrition, how it shapes the future life of the child. But to see this allergy which is mingled with this 1000 days concept is a very unique. It means that definitely in this period where the gut microbiome can interfere and alter the immunological system in such a way whether the growing infant is going to overcome the allergy or it is going to be sensitized or going to develop allergic diseases which can be made out very early so that appropriate interventions can be made out. So it is a really thought-provoking and really but unutilized, unknown to many of our pediatricians. Moment I saw the topic, then I went into that literature. A lot of literatures are upcoming. Definitely it will be a very unique topic because it is not only the infants, because 1000 days, mother's microbiome can also alter the infant gut, which can produce allergies in children. So whatever exposure to drugs, antibiotics, diet, everything can count on the fetal and infant microbiome. So definitely I do not take much time. I'm really honored that this allergy chapter is bringing a lot of unique webinars and which is very useful to the practitioners. My humble request, Neeraj sir, you should all record it and you should give it to our, so that our IAPNs can be benefited, because this is a peak of the time where many of them are in the active practice where they may not be able to listen, but many of the postgraduates are being benefited. I'm sure under the moderatorship of Dr. Nandana Bala, our speakers will deliver, and our own person Vivek is here, and everybody will deliver a very good, lively and very useful to the practicing pediatricians, which can change, because I always talk about this. Future all IDs are coming down, infectious diseases are coming down, whereas allergies are increasing. The future of pediatricians, because of the vaccines and all that, allergy is going to be the main factor. So many of our general pediatricians are taking now allergy courses, and whenever we introduce an IAP allergy courses for a short while, it is the first one which get filled up. So that much the importance is gaining. Definitely today deliberation will make a great usefulness to the practitioners. And I once again thank Neeraj sir for inviting me, giving this great honor of joining with you and giving my inaugural address. Thank you. Thank you for, and wish you all the best for a happy learning today. Thank you. Thank you. Nice.
Thank you, sir. Thank you for your
Thank you.
blessings. And just for your knowledge, that we are already on live on the YouTube channel, and the chapter YouTube channel has over 2,200 subscribers in past 9 months. So all the webinars, all the activities which have been done in past 1 year, they all are available live at any time. Anybody can see, anybody can subscribe. So thank you so much, sir, for such an opportunity and such a lovely blessings. So we are also extremely fortunate to have with us an eminent nutritional expert, Dr. Robert Boyle, commonly known as or lovingly known as Bob. Dr. Bob is a consultant pediatric allergist in London, based at St. Mary's Hospital, Imperial College Healthcare NHS Trust, and holds important academic roles at Imperial College London. He is the chief editor of Clinical and Experimental Allergy and has made seminal contributions in the areas of food allergy, eczema, asthma, and allergy prevention. Including his work with Cochrane Allergy Reviews, his presence truly elevates the academic stature of this webinar, and we are grateful to him for sharing global insights with us. Thank you so much, Dr. Bob, Dr. Boyle, for joining us today. So I would like to invite you to say a few words before we formally start the webinar.
Thank you. Thank you so much for the kind introduction, Niraj, and Nandana, Professor Singara Velu. Thank you so much for your kind invitation. It's an absolute honor to speak to the IAP as probably the most respected international pediatric body in the world. So thank you for the opportunity. I'm going to talk about the beginnings of allergy.
Bob, sorry, before you start, I would like to introduce our moderator for the day. So I would also like to acknowledge our moderator, Dr. Nandana Bala, a well-known pediatric allergist from Bangalore, who brings rich clinical expertise and academic clarity to this session. I am confident that under her able moderation, today's discussions will be focused, engaging, and clinically relevant. I extend my sincere thanks to all the esteemed faculty members, including Dr. Sitesh Roy sir, who have taken time from their busy schedules to contribute this important topic, and to all the participants who have joined us from across the country and outside the country also. With this, I once again welcome you all and formally inaugurate today's webinar. I am confident that the next 2 hours will be intellectually stimulating and immensely beneficial for our clinical practice. Thank you, and I wish you a great success for the webinar. Dr. Nanda Bala, ma'am, please take over from here. Thank you.
Thank you so much. So first of all, my sincere thanks to Indian Academy of Pediatrics and IAP Allergy chapter for this wonderful opportunity to conduct and curate this webinar today. And Professor Singaravelu sir, thank you so much for joining us today. Such a privilege to have you here, sir. And Dr. Neeraj, thank you for your dedication and tireless efforts to improve knowledge and practice of allergy in India for the benefit of our patients. And my sincere thanks to Dr. Robert Boyle, who was my teacher 12 years ago, for agreeing to do this important session for us. Thank you so much. And as we all know, Dr. Boyle has done a vast amount of research in the field of allergy prevention, and we are so fortunate to hear the keynote lecture from you today. And my heartfelt thanks to Dr. Sitesh Roy. Thank you so much for agreeing to talk to us today and share your expertise with us. Dr. Sunila Nayak and Dr. Vivekanand will be joining us later in the session. So we have an extensive session planned for tonight with experts in the field. And our topic for today is first 1,000 days, the allergy development and prevention. So we will go through the determinants of allergy, from conception till 2 years of age. So I now request Dr. Robert Boyle to share his screen and talk to us about this very important topic. Over to you, Dr. Boyle.
Thank you. Thank you. As I said, a great honor to be present this evening. I'm based at Imperial College in London. I'm a practicing pediatric allergist for the last 20 years and run an academic program around mainly allergy prevention. Start just by putting my declarations of interest in case of any sense of biases or relationships that might influence what I'm going to say today. I won't read through them, but they're there for anyone who's interested. I'm going to talk today about three things, really. The first is going to talk about the epidemiology of allergy, so the pattern of allergic conditions, how common they are, how things have been changing over time. And the second thing I'm going to talk about is really to focus on, well, what do we know about prevention, what does work, and think about how to implement that in practice. And then I'm going to finish with a couple of cautionary tales from the Western allergy experience, where I think where we've perhaps a little bit earlier than India, we saw apparent increases in allergy, and one or two of the things that we did which were wrong and perhaps caused more harm than good, just to share those experiences. So if we talk a little bit about the epidemiology first. This is a pot which is about 5,000 years old, and it depicts a pharaoh, Pharaoh Menes, and he was a very important pharaoh in ancient Egypt, and that means that his life was very carefully described. And so what we know from his life is that he had an itchy skin condition all of his life, and that he died within minutes of being stung by a wasp. So Pharaoh Menes is thought to be the first recorded person with eczema, and the first reported person who had anaphylaxis. He's thought to have died from anaphylaxis due to a wasp sting. And I think that makes a couple of points which are relevant to today's talk. The first is that allergy is probably not a new thing. It's been around for at least several thousand years, probably much longer than that. And the second is that allergy, on the whole, over recent centuries at least, has been portrayed as a condition which affects the upper classes or the wealthier members of society more than poorer parts of society. And we'll see that a little bit as we go along as a recurring theme. So the first sense we have from the history books is that allergic diseases may be something that's more common in wealthy people, or at least better documented. And what we see, across the world in the last couple of hundred years is a very fast rising increase in per capita income since the Industrial Revolution in the late 1700s, and really through the 1800s, individual humans becoming much wealthier than ever before. And associated with this, we get a sense from the history books that allergic conditions became more common, around the 1800s. So, for example, if you look at hay fever or allergic rhinitis, perhaps the first record in the history books is from an Islamic scholar who recorded in 865 a description of people whose heads swelled up and they got catarrh in the summertime. But it was really a very rare thing in the medical literature until the 1800s, where we had the first description of hay fever in 1819 by John Bostock. He was describing himself, and he found, it took him about 9 years to discover another 28 cases to write up. But by the end of the 1800s, in England at least, this GP, this family practitioner, Charles Blackley, was recording that he thought that hay fever was on the increase. And in the literature in the 1800s, you get this sense when reading what people wrote that hay fever seemed to be becoming more common or better recognized, and it seems to be more common in the wealthier classes. So, and that was written by several physicians, said the same thing. So there's a sense that hay fever is something that seems to be more common in industrialized societies. And as we go through the last century, the 1900s, we have this, the history books sort of tell us that hay fever was an important thing. Leonard Noon, working in my hospital in 1911, invented a treatment for hay fever, desensitization, so pollen injections. And you've got evidence from the United States that in New York in the 1940s, you've got a campaign to try and get rid of ragweed, the main cause of hay fever. So hay fever obviously seen as a big problem in New York by the 1940s, something that was impacting on the workforce, on the economy. It needed a statewide solution to try and reduce symptoms. So I have a sense that during the 1800s, the early 1900s, hay fever, emerged as a big thing, and then we hear about asthma becoming more common in the sort of second half of the last century, and then we get studies like this, which spawned the hygiene hypothesis. This is David Strachan's original paper, which spawned the idea that there's a relationship between infection and allergy. We saw that in the previous slide, that infectious diseases mortality was dropping like a stone in the last century, with the exception, this is in Europe and the United States, with the exception of the flu pandemic there. And then David Strachan saying, hey, look, people who come from higher class families where the father's got a better job, or people who are firstborn children instead of lower-born children, seem to have more hay fever. And he proposed that this might be something to do with bugs or infections or crowding. There's something about living in a crowded or impoverished home which protects you from getting hay fever. And again, you see here from 1958, but British birth cohort rates were lower than they were in the 1970 birth cohort. So again, there's this sense that, as societies industrialize, urbanize, become wealthier, there seems to be more allergic disease present. And the thing that's changed really in my working life is from the early 1990s, we've had this sense that anaphylaxis, so severe allergic reactions, may be increasing, particularly in young children. So this is 0 to 4-year-old children in Australia. The number of hospital admissions for severe allergic reactions, so classified as anaphylaxis, increased markedly over a very short period of time, over 10 years. We've got a sort of 5, 6, 7, 8-fold difference in increase in rates, a very, very fast increase. And those reactions are almost all caused by food allergy. So this was part of what became to be known as the food allergy epidemic. So working in sort of Western countries in the late 1990s, early 2000s, you have this sense that more and more children are wheezing and coughing and getting eczema and acute allergic reactions, and mild or severe ones, some intestinal allergic inflammation. A lot of this stuff becoming more and more common. And what you see now already in the literature and the media and just talking to physicians in India is this sense that the same thing is happening in India. So this is a piece of media and publication, the idea that there's an allergy epidemic, that anaphylaxis is becoming more and more common. And that gives a sense of insecurity really about in the population, and urgency to improve allergy services, etc. So I want to step back from that, because that's the sort of, I think most people around the world would say, oh, allergy is increasing, and it's increasing in different parts of the world at different rates, and that includes anaphylaxis. But I want to look at the best research we've got so far on how common these things are. I've shown you a few things just now, but this study, the ISAC study, really is a step better than everything I've showed you so far, because the ISAC study was created in early 1990s by David Strachan, who coined the term the hygiene hypothesis, and Hal Williams, my colleague and mentor, and many other leading dermatologists, respiratory physicians, allergists, epidemiologists of their time. The ISAC survey at the time was the largest epidemiological study ever conducted in the world. So almost 2 million children were surveyed in over 100 countries, including India. And the whole point of the ISAC survey was to try and understand, well, how common are these diseases? We think they're increasing. Everyone's seeing more asthma, eczema, hay fever. This was before people started worrying about anaphylaxis and food allergy. They're seeing more. How common are they? And how fast is things changing over time? So the ISAC survey was always planned to do one international survey and then repeat it some years later to see how things are changing. And this is what ISAC has shown us for asthma, for example, that there's quite a lot of variation between countries. So some countries appear to have higher rates of asthma in children than others. And actually India tends to be at the lower end. So although there are obviously a lot of people with asthma in India, the rates, at least up to 2020, seem to be quite stable, if anything, declining in most of the Indian centres and lower than most other countries in the world. And remember, all countries are using the same methodology to establish how common asthma is in this very large piece of epidemiology, covering about 30 years. So it's surprising, isn't it, when we think that allergy is increasing everywhere, that more people are aware of it, more people going to hospital, more people having treatments and diagnoses, that actually the best epidemiology we've got is not really showing any obvious change in asthma, at least over that 30-year period. And that's true for 6 to 7-year-olds and also 13 to 14-year-olds. You could take one centre, say, oh, it's going up there. You could take another one, say it's going down. But the overall picture is not one of a dramatic increase. Very similar picture for eczema, where you've got also the lowest prevalence of eczema was in the centres from India. And the rates appear to be quite stable over those almost 30-year period, with no overall clear change in rates globally. And it's actually true with food allergy and anaphylaxis as well, as far as we can tell, but the numbers are harder to get. It's harder to study the epidemiology of anaphylaxis and food allergy for various reasons. So despite the sense that anaphylaxis might be increasing numbers of hospital attendances, increasing number of people coming to clinics saying they'd had anaphylaxis or had reactions, proper anaphylaxis, so death from anaphylaxis, there's no question that was a life-threatening reaction, don't appear to be increasing. So in the UK, we've had tons of studies saying that anaphylaxis is increasing. The rates of people coming to hospital due to an acute allergic reaction, which is labeled as anaphylaxis, has been increasing from the early 1990s and continues to increase year on year. But actual death from an allergic reaction is not changed. And so it's a sort of, there's a discordance here. You say, well, more and more people are having life-threatening reactions, but no more people are dying. So are those reactions really life-threatening, or are we actually relabeling things and saying that's, anaphylaxis when in previous years we might have called it just an allergic reaction? And we see that internationally. It's not just the UK, where we've got a sense that death from anaphylaxis does not appear to be increasing, thankfully. I mean, the data are imperfect. You could take one country and say that looks like it's increasing. You get another, say it's decreasing. But the overall picture is one of relative stability. So it's reassuring, but it's also quite hard to understand this if allergy really is increasing in other ways. If we look at food allergy specifically, as I said, it's very hard to get good data on food allergy, but there are 3 or 4 studies where people have carefully measured some sort of assessment of food allergy, separated by 10, 20, 30 years. So this is a US study where they looked at blood samples from people born in the 1970s to 80s, taken as children. And then again, from people born in the 1990s to 2000, again, taken during their school years, age 6 to 19. And there's no sense of any increase, in fact, a slight decrease in allergy antibody levels to shrimp. This is from Australia. These are allergy skin prick tests in 1-year-olds in Melbourne, born in 1994 and 2010 to 2011. And again, no sense of any increase in allergic sensitivity to eggs, peanut or milk, which are the commonest allergens at that age in Melbourne. And then we've got our UK study in the Isle of Wight, where almost the whole population of almost all births in the Isle of Wight were enrolled in a cohort study in 1989 and again in 2002. And food allergy was carefully evaluated at various time points over life in the first cohort. And the second cohort, there's no, well, slight decrease, if anything, but certainly no increase. So got this very strange dichotomy that when society is industrialized, people see it before their eyes. There's more hay fever. I never used to see these many cases. My relatives didn't. People are having more allergic issues. They seem to be having more asthma, more eczema, more food allergy, more acute allergic reactions. But the best studies are telling us the rate of change, at least, is not very fast at a whole population level. That there are changes, but they're not super fast. These sort of 5-fold increases over 10, 15, 20 years just don't really hold up when you look at the best epidemiology. So you've got to find another explanation. Why have we got this sense that allergy is increasing much faster than perhaps it really is? And I think I'd put out there a possibility that some of what we're seeing is real, that allergy is more common when societies industrialize and urbanize. But some of what we're seeing is a sort of piggybacking on the back of that, people launching products, whether it's asthma inhalers, which were launched at the beginning of the so-called asthma epidemic, or whether it's adrenaline autoinjectors, which were launched at the beginning of the so-called anaphylaxis epidemic. The marketing that goes with the launches of those products, I think, is also heightening people's awareness, concern, their healthcare seeking behavior, heightening our tendency to make a diagnosis and avoidance, etc. So I think there's some confusing signals which are related to marketing on top of the reality, which is that, you know, if you're in a city and you're in a higher income sort of setting, then you're going to have quite a bit of allergy. If you're in a more old-fashioned rural setting, your allergy rates are going to be lower. So that's all I wanted to say really about epidemiology and what we're dealing with. I think we've got two parallel things going on. We do have a genuine sort of increase in allergy when societies industrialize and urbanize, but then we've got a sort of marketing narrative which plays on that and sometimes exaggerates that and leads to different healthcare seeking behavior. So I think a lot of what perhaps you're seeing at the moment in front of your eyes in India is probably, you know, there's some real increase in allergy, but a lot of what you're seeing is probably behavioral change, which is what we've been seeing in the UK in the last 30 years, that, you know, people more concerned, more aware about allergies, seeking treatments more often, but some of it's real. So let's think a little bit more about allergy programming and early life, because we know, you know, as pediatricians, we know that allergies start early. And there's that variation across geography and society and a variation across time, which means that surely there's something you can do to prevent allergies. So people have been looking quite hard at allergy prevention interventions for at least 50 years. We haven't got very far. So I was asked, well, our group was asked by the UK government to look at all the nutritional interventions around allergy prevention, indeed autoimmune disease prevention, looking at milk feeding, introduction of allergenic foods, dietary changes during pregnancy, lactation, or the first year of life for infants. So most of this first 1,000 days, and nutrition, which is, you know, an important potential driver of allergy. And we looked at everything a few years ago, and essentially, I'm not going to go through all the details. There's a lot there. If you look at the bottom of this, you'll see the main interventions that have been tried over the years. Special formula milks, microbes like probiotics, anti-inflammatory fatty acids, timing of allergenic food introduction, allergen avoidance. Those are the main things that have been studied in randomized trials over the years. And I'm going to hone down on just one of them because only really one of these worked. And that is oral tolerance. And oral tolerance refers to an immune phenomenon discovered by a scientist called H.G. Wells. Now, we've got a scientist we're very proud of at Imperial College called H.G. Wells, but he's only famous because he wrote books. He wrote science fiction books like The Time Machine. The H.G. Wells who discovered oral tolerance was an immunologist from Chicago who had been studying this phenomenon called anaphylaxis, which was described in 1906. And he was studying it in his laboratory where he took little guinea pigs and he injected guinea pigs under the skin with a little bit of chicken egg, with egg white. And what he found was that if he injected them a few times with egg white, they would eventually start to swell up and react. They would have induced anaphylactic reactions in the guinea pigs by injecting them with repeated time points with chicken egg. But the exciting discovery that H.G. Wells made was that if he put egg in the baby guinea pig's feed before he started the injections, couldn't make them allergic. And that's a very powerful immunological phenomenon, that if a baby guinea pig is eating chicken egg, whatever you do, you can't make them allergic to chicken egg because they've got what's called oral immune tolerance. And it took another 100 years before that was shown to work in humans by Gideon Lack and team in London, who did this very famous trial called the LEAP trial, where they showed that feeding babies peanut butter or peanut in some form could prevent them from the future development of peanut allergy. So again, the same thing, if they're regularly eating peanut, then it teaches the immune system to tolerate peanut, and then they won't become allergic to it in the future. And in fact, that's been shown now for a number of foods that essentially by including common allergy foods in a baby's diet when you introduce solid foods, you can reduce the chance of them getting allergy in the future. But it's not always very easy. Feeding babies is as much art as science, and to try and get them to eat, lots of different allergy foods is not very practical. So really, the way this science has been interpreted by public health authorities, such as there are one in the UK, is that when introducing complementary foods to a young child's diet, to a baby's diet, then any common allergy foods that are eaten at home should be included. So, if family eat a lot of fish, then fish can be included. This is not very different to general WHO or national dietary advice to introduce family foods as the main foods for children when you introduce complementary foods to their diet. And I think I've just encourage, that there's a very nice WHO guideline on complementary feeding of infants and young children, which takes all of this into consideration and only came out a couple of years ago. And I'd advise, I think when we're thinking about infant feeding, the first 1,000 days, IAP is very well aligned to a WHO, etc. I wouldn't deviate from that. And I think you need to be careful in the allergy world, because most of the allergy academies outside of India are sponsored by nutrition industry, and they tend to have all these alternative recommendations which really undermine public health guidance, and they're not well scientifically based, they're not evidence-based, they're really about bias and conflicts of interest and nutrition industry funding, and are best ignored. So I think when thinking about infant feeding or basic public health questions, it's best to go to the public health bodies rather than the specialist academies, which tend to have financial conflicts that push them in the other direction. In fact, her colleagues looked at conflicts of interest in allergy healthcare professional organizations around the world recently, and they found that the vast majority of allergy healthcare professional organizations around the world are taking funding from the nutrition industry. So it's unusual to align with WHO code in the allergy world. They could only identify one society which was following WHO's advice to not take funding from the nutrition industry. So just a word of warning there in terms of implementation and guidelines, that the public health guidance, and I know in India with the IMS Act, is very clean compared to some other parts of the world. Need to be careful not to overdo the allergy and undermine public health guidance. So the last thing I want to touch on, which sort of follows on from that really, is a couple of cautionary tales from the Western allergy experience. And the first thing to remember really is that the whole infant, young child nutrition environment in the West is very different to in India. I mean, this is a few years old now, but this is breastfeeding rates in different parts of the world. In India, the median duration of breastfeeding is, I understand, 32 months. In the UK, the median duration of breastfeeding is 39 days. So this is a completely different infant feeding environment, and it's been highly commercialized for more than the last 100 years ago. So our late Queen of England was bottle fed. So the infant feeding in the UK, Europe, North America, it's got a very different history to the current status of infant feeding in India. And you can see that in some numbers. So this is the amount of formula sales per baby born in India from Euromonitor data. And this is in a couple of other countries, including China. And notably in China, what happened in 2017 is some WHO guidance was removed from national regulation, and this coincided with a steep increase in formula consumption, formula marketing in that country. And it's a very live issue, as always, and I'm aware that in India there's a lot of active debate around these areas. The Infant Milk Substitutes Act, the IMS Act, is is, in danger of being watered down, and it's being violated from, not infrequently. This is a typical example of American nutrition company sponsoring a dietitians forum. So it's not a sort of stable, safe place. It's a dynamic thing, and the reason for the IMS Act and the WHO guidance, etc., is the harm that can be done through health professionals and receiving sponsorship from nutrition companies. So I'm sure you're all well aware of that, but I just wanted to put that out there. What's that got to do with allergy? Well, the first word of warning is this, which is the hydrolyzed formula story, because for about 30 years, Europe, America, and actually much of Asia was convinced that this special hydrolyzed formula was the answer to preventing allergy, which it isn't. So until a few years ago, we had things like this on our websites and shelves in the UK. Similar things around all those parts of the world I've mentioned. This is an American advert. And our professional guidelines, again, from academies that are largely sponsored by the nutrition industry, but they're things like the European Allergy Academy, the American Academy of Pediatrics, the American Allergy Academies, the Asian Allergy Academies, etc. They all, the gastroenterology academies, they all endorsed this formula as something that could prevent allergies and eczema. I believed it. Everyone I worked with believed it. All the academics in the field believed that this was, this thing could prevent allergies, but it's not true. And it's that, in the last 5 years, those claims have been withdrawn everywhere around Europe and North America and most of the high-income countries of the world. These claims are still made in some parts of the world, but they're not true. And they've relied on fabricated trials. They're trials sponsored by the nutrition industry, which turned out to be fabricated. And they relied on misreporting of clinical trial results. So there was, for example, this trial was buried for 15 years, null trial. And this trial, which was also null, had selective data points reported. They basically carved it up and analyzed data and, on a small subset of the population and only published those, which made it look exciting. So issues with clinical trial practice, with sponsorship, with fraud led to these misleading claims. So that's the first word of warning, is that when the nutrition industry is saying we've got this really exciting formula product that prevents allergy, don't believe it. It's very unlikely to be the case, and there's a lot of misinformation around that sort of area. And the second word of warning really is a very active and current thing. I think the hydrolyzed formula story for preventing allergies is largely historic. Most people have withdrawn those recommendations from guidelines, etc. You don't see the adverts, at least in Europe anymore. This area is very active around the world, and this is the promotion of low allergy infant formulas. So again, it's the allergy world kind of being used to undermine public health and child health. So these low allergy formulas, where there are various different forms, they can be soya, they can be extensively hydrolyzed amino acid formulas. They are prescribed in vast quantities in many high-income countries now. So these are the data from England. We've got about a 5-fold increase in prescribing rate over a very short period of time. And on the bottom here, you've got the expected prescribing rate if they were used for their approved indication, which is cow's milk allergy. So you've got the vast majority of prescriptions of these products are not for clinically indicated reasons. And what that means is about 1 in 10 infants in the UK is prescribed one of these low allergy formula products at the moment, and they're usually for non-specific early gastrointestinal symptoms, which we all know as pediatricians, they affect most babies in the first weeks of life. And that's when these prescriptions are being initiated, in the first couple of months of life for non-specific GI symptoms. The sorts of GI symptoms that Shakespeare described many hundreds of years ago, they're not new, they're not caused by allergy, they're developmental symptoms which we see in babies: funny poos, vomiting, crying, rashes, etc. That contrasts with true milk allergy, which has a slightly later onset and affects many less children, less than 1% in this European study, which is the largest study conducted so far, and presents as a reproducible reaction to cow's milk ingestion, not as non-specific symptoms. So it's the second word of warning, is to sort of try and avoid following what the West has done, which is to transition a lot of people from healthier nutrition onto these low allergy formulas, which are very high in free sugars. So most of the low allergy formulas have maltodextrin or glucose syrup as the main carbohydrate source, and that means that you're exposing infants to very high intake of free sugars, and that's the number one thing that all the public health authorities, from the WHO to national authorities, say that we should be trying to reduce in the diets, particularly of young children, where they can promote obesity and dental decay and lifelong increased risk of various metabolic diseases. So I'm going to stop there, just to summarize my main points, really, which are that allergy is more common in urban industrial societies, and the reasons for this are not known. I'm sorry not to give you the answer today, but there's a lot behind that, and we can talk about it if another time if necessary. But we do know that regular consumption of allergy foods such as egg or peanut, if a family eat peanut, or other allergy foods that the family may eat in the first year of life, can prevent food allergy through the mechanism of oral tolerance. And finally, really, I think hopefully what's come across is that the nutrition industry marketing and other, adrenaline auto-injector marketing, etc., can cause confusion in this area of science, and it can sometimes make things feel more dramatic and prevalent than they really are. Thank you for your attention.
Thank you. Thank you so much, Dr. Boyle. So what particularly struck me is, like a word of caution against, falling for the marketing world. And I think, in a way, you told us about, learning from mistakes of the West. And I think, that is a point well taken. So, it was very nice of you to acknowledge that, there were mistakes made, and that is, I think for us, main thing is to learn from them, and so that we don't repeat them here. We have a lot of, constraints here in India, but I think the main thing is to continue doing what we're doing. And you showed us about the high breastfeeding rates, and that is so much true, compared to how it is in the West, and that is definitely protective, and we're doing a favor to our children by continuing with that, and sticking to our traditional diets, which we believe is protective. So yeah, thank you for that. That was an amazing talk, and again, our privilege that you spoke to us today.
Thank you.
I would like to invite our next speaker, Dr. Sitesh Roy. I think, Dr. Sitesh, you're here, right?
Yes.
Yes, yeah, welcome, Dr. Sitesh Roy. So, Dr. Sitesh Roy is a US certified specialist in allergy, asthma, and clinical immunology. And he's the founder of Dr. Roy's Health Solution Clinics in Mumbai. He was voted amongst the best doctors in America for several years in a row. And he has authored a number of articles and publications for leading medical journals. A true academician and an excellent clinician. We are fortunate to have you here, Dr. Roy. Over to you. You can start screen share, please.
Are you all able to see my screen? I've already shared it.
Yes.
Okay, great. Thank you very much, Dr. Nandana, and a special thanks to Indian Academy of Pediatrics, to the President-elect, Dr. Sringavelu, and to Neeraj Gupta. It's my pleasure being here, speaking on a topic that has been very close to my heart ever since I got interested in the field of allergy in the late 90s. Story of rising allergies worldwide. You have heard an excellent talk by Dr. Boyle just a few moments ago, but it seems and has been discussed multiple times that increasing exposure to environmental agents related to industrialization, urbanization, modernization, as we would call it, is one of the underlying reasons that we've seen rise in allergic disease and inflammatory diseases. They go hand in hand, Th1, Th2, two sides of the same balance. And that's what we call the autoimmune disease and inflammatory disease. And westernization of the diet and lifestyle, stress, immune dysregulation, rise in allergic autoimmune diseases is a very, very common problem that we are seeing. This is a summary of all the things that I'll be going through in this talk. So right from the impact on the mother of an environmental microbial diversity, to the maternal antibiotic exposure, dietary habits, maternal stress, environmental exposures, which we shall look at, including pollutants. There is a lot that influences the mother, her immunity, her gut, and eventually through the fetal-maternal pathway, where the maternal microbiome, the placental, and the fetal microbiome connect with each other through a variety of these different methodologies that you can see, then leads to the risk of either having a regulated immune system or a dysregulated immune system. So regulated would be good. That would be a tolerance and protection. And the dysregulation would really be an issue where the infant is going towards a Th2 pathway or an inflammatory pathway. When we look at this with a little bit more expansion so that you get an idea of all the topics that I'll be covering today, you will see that within this we have maternal smoking. It's a no-brainer, right from affecting the baby's lung growth. It has multiple other effects on the mother and eventually on the baby. Allergens, which can play a role, especially if the mother is atopic and has allergies. It has been shown that that translates into a higher transmission of what we would call a Th2 kind of pathway into the baby, so much so that cord blood IgE has shown quite a lot of changes in such mothers who are atopic. Antibiotic use, the kind of dietary nutrients that they take, farm environment, and certainly the impact of other environmental exposures that we shall talk about. Now, if we look at the impact both through the maternal metabolism, we shall see some pointers toward that in terms of the maternal obesity or maternal inflammatory markers, to the maternal microbiome and the immune system through these all different mechanisms, which I really would not have the time to go through in a half an hour lecture, but this is a really growing, evolving, and I would say futuristic field in some ways, because this is where we start thinking, how can we prevent allergies? We all along talk about treating allergies, but this is about prevention. And then through the various mechanisms of developing mucosal barriers, sensory innervation, offspring immune system, offspring microbiome, and developing organs, we can see that the allergic predisposition may either be low or high, depending on all these factors. So let's look at some of the features of this thing. This is a summary slide, and I'm putting it at the beginning because we will go through each of these things. But what is being tried in this field is right from maternal dietary interventions to microbiome manipulation to infant dietary interventions, which is not the purpose of this talk, and skin barrier interventions, which is also not the purpose of this talk, to also recognizing how environmental exposures modulate the mother's and the fetus's immune system, so that we can then end up either with a pro-allergic or an anti-allergic environment for the baby. And I think this is a picture that kind of denotes the entire process of having tolerance versus allergy, very classically described for atopic dermatitis. And again, just to put the point here that there are external and internal factors, right from the nature of the baby's skin barrier to what the mother has been through in terms of stress and psychological distress through pregnancy. There are many, many factors that can influence these diseases ultimately manifesting at very young ages. And when I went off to the US to do my residency and then fellowship, I used to hardly see kids with atopic dermatitis or asthma, even at a big hospital like King Edward Memorial Hospital, GS Medical College, when I was training there as an intern. And when I came back, and every time I came back for the 14 years that I was in the US, I would come back once a year. I was alarmed to see at the rate at which these diseases were increasing. And today it's not unusual for me to see a 15 or 10-day-old baby with eczema which I used to almost never see before. When we look at prenatal causes, just to list them out, we recognize that antibiotic usage for the mother, dietary habits, vitamin deficiencies, especially vitamin D, has been looked at. Improved sanitation, which goes with the hygiene hypothesis, but the hygiene hypothesis is far more expansive than was first described in 1989. The biome depletion, cesarean delivery, which kind of keeps the child away from the microbial seeding, as I may call it, that occurs during a normal vaginal delivery. Formula supplementation, which you have heard a lot about, and all of this can profoundly deplete the baby's immune system within the first 48 hours of life. Now, there's a very, very active feto-maternal immune axis, and this transfer can occur through many immune mechanisms, which I'm not going to go through currently. But in this, one has to realize that there is a prepartum or a prenatal transmission that occurs. And then there's a postpartum transmission, which largely occurs through lactation and everything that goes around breastfeeding. But everything from breastfeeding to kangaroo care and everything else that we know about as pediatricians is still very, very important. These are some of the depictions of how the fetal gut, maternal gut, maternal immune system and fetal immune system interact. And in this, some of the strongest data that comes out is from having looked at differences between rural environments or farming environments and urban environments in terms of allergy prevalence. Now, data in Europe, very nicely done in Germany and other parts of Europe, Asia, including India, United States, Africa, have shown that early life exposure to a traditional farm environment is associated with reduced risk of allergic disease and asthma. And interestingly, the prevention of allergy risk factors for sensitization in children, a study called the Parsifal cohort, was large enough to show that prenatal farm exposure may be more protective than postnatal farm exposure, which is what some people, when they see this data, they believe that if they start doing that after the baby is born, while there may be some benefits to that in terms of stress reduction and a better, cleaner environment, at least in India, the impact is much larger when the mother has been pregnant and lived on a farm before the delivery of the baby. And this is where my interest, as early as in 2003, we had published this data. Andy Liu, who was my mentor then and program director at National Jewish Medical and Research Center, looking at bacterial DNA in house homes, urban homes, and farm barn dust. There was also data on endotoxin, and then obviously this data has burgeoned and grown immensely, where data on the US Amish cow farm dust versus European cow farm dust and the European sheep farm dust. And interestingly, the cow farm dusts are supposed to be protective and the sheep farm dusts are not as protective. And there are multiple factors beyond endotoxin, bacterial DNA, heat shock proteins, including allergens combined with healthy haptens or microbiomes that can really alter the way the immune system sees an allergen. Some children, because of this microbial pattern recognition, toll-like receptor 7 and 8 receptors getting equipped very early in infancy from living on the farm, this makes a huge difference because we know that rhinovirus and RSV and other viruses like this are the reasons why kids wheeze early in life. And for that wheezing to turn into a Th2 disease and become an allergic asthma or an allergic inflammatory disease doesn't take time. And really, many such pathways have been shown, but ultimately the T regulatory system and the toll receptor system, which modulates the way the baby after birth will respond to the environment, makes a huge difference. Taking a step further, looking at maternal diet and allergy risk, food intakes that are high in refined sugars, saturated fats, omega-6 fatty acids, and low in fiber and omega-3 fatty acids have been purported to alter the beneficial bacteria in the gut. And because of the not healthy bacteria, because of this kind of a maternal diet, you would see more of E. coli, staph, and Enterobacteriaceae, which is more prone to cause inflammation and disease. Again, looking at the household characteristics, pets which are present before the baby is born, not getting one after, alters the microbial composition in the home. If the mother is a smoker or is with passive smoking at a high quantity, that can make a difference. The baby's gut and microbial community composition changes, and then you look at all the exposures that happen after birth, including air pollution, which is a big issue in many parts of India, and now you have a persistent immune response that goes towards atopy and asthma. Within the maternal scenario, chronic stress for the mother, inflammation, obesity, poor diet, we already heard. Combine this with chronic diseases like constipation, excessive weight gain, all of this can really impact how the mother's immune system and hence the baby's immune system will be altered when it comes to the bacteria, the microbiome that is there in it. Antibiotics also have a profound impact, and maternal treatment with antibiotics in pregnancy has been linked in some studies to eczema, food allergy, and asthma in the offspring. These studies are not always reproducible. There are some studies where the effect has not been seen. But interestingly, the susceptibility to infections for the mother is something that even outside of the pregnancy period, means pre-pregnancy, also ended up being a risk factor for asthma in the child, suggesting that some other deeper immune mechanism may be at play. We've all heard about fatty acids, which are important building blocks both in the gut and the mammary tissue. And this, especially the polyunsaturated fatty acids, what we know as the short chain fatty acids, have a big role to play in how the pro versus anti-inflammatory immune response in the mother's gut and eventually in the baby will occur and alter how the baby ultimately responds to the environment. Maternal microbiome with consumption of probiotics, high fiber foods, which act as prebiotics, lead to more of the lactobacillus bifidobacterium, which have been suggested to be somewhat protective when it comes to the Th1 pathway and the non-allergic pathway. And hence, things that can be done to alter the mother's microbiome and ultimately the infants or the fetus and then the infant's microbiome are areas of immense interest, and I will show a few data related to that. So as we have seen, when someone lives on a farm, they're exposed to a lot of environmental microbes because they are living in a clean, relatively what I would call clean, not as in like hygienic clean, but relatively clean air, clean water environment, less infections, good diet, rich in vegetables, fruits, low stress. All of this can ultimately alter the way the mother's and the baby's immune system responds and ultimately lead to less inflammation, which is what promotes the development of allergy. Interestingly, maternal exposure to pollutants, including air pollution, and we have, as you all know, in some cities, very, very high AQIs this time of the year. Ozone, diesel exhaust, all of these can modulate the T2 and the non-T2 inflammatory responses. Air pollution also impacts the microbiome, which is very interesting data if anyone wants to look into it. It can have a negative impact on lung function because of the airway microbiome impact. Micro and nanoplastics have also been shown to go through and cause inflammation. And then ultimately, even the routine stuff that we use for day-to-day, like detergents, surfactants, dishwashers, liquids, toothpaste, a lot of chemicals go into this. Anyone who studies contact dermatitis knows that we say something that if you look at all the things you use on your body or in your body from the time you wake up till the time you go to bed at night, on an average, you're exposed to about 100 chemicals that some of them, we do not know what they do to the immune system. Which brings us to a very interesting study published in 2022 in Allergy, where Karina Venter and her team looked at a high vegetable and fruit diet, so vegetable and yogurt diet, versus a diet that was rich in red meat, cold cereals, fried potatoes, refined grains, and 100% fruit juice. And what they found, the odds ratio of having an offspring with allergic diseases for allergic rhinitis reduced by 18%, atopic dermatitis 23%, asthma 16%, wheeze 20%, and food allergy about 16%. Clearly suggesting that there is some role for the maternal diet, and having a healthy maternal diet can make a difference. Similarly, a very interesting study that got recently published in 2025 by Ching et al., they found that maternal avocado consumption, so high fat food, high fiber food, there was a 436% reduction in odds of reported food allergy at 12 months in the offspring. And this remained persistent even if you corrected for maternal age, marital status, education, parity, BMI, and many other factors that we feel could influence this result. So again, this is not a very large number of children, but very interesting data. Maternal diet that is rich in fiber increases an old form of bacteria called Holdemania. It's a family. And this is what we call the ancestral gut microbes. And these microbes are reducing with time. The low fiber diet actually contributes to these ancestral gut microbes going away. And these are the microbes that can give us the short-chain fatty acids, which can be protective. Taking a switch, now we look at maternal stress and infant wheeze. There is several studies that have shown that maternal psychological stress and mental illness during pregnancy increase the risk of allergy, asthma, but primarily of wheeze in the first year of life, and also to some extent of atopic dermatitis. An interesting study again here of about 442 children who were followed with mothers' maternal depression scales and stress scales being followed. Depression actually led to increased wheezing in the first couple of years of life, which was non-atopic in nature. And wheezing illnesses in the first 3 years of life in kids who were primarily born to mothers with high perceived maternal stress. These could be atopic or non-atopic, but the ones in the non-allergic group were primarily in the depression group. The fetal and maternal microbiome really have a very strong crosstalk, and this crosstalk eventually predicts whether the infant's postnatal gut microbiota will be at risk for allergies or not at risk for allergies. And I'm not going to go through the mechanisms in the interest of time, but there are multiple mechanisms by which it actually crosstalks. And when we look at the delivery status, mothers who have a vaginal delivery, even in them, the mother's gut contributes about 22% of the bacteria that are eventually found in the baby's gut. And if they are born by a cesarean section, they have decrease in these bacteria, and these, if not restored, either through orofecal microbial transplant or some other mechanisms which are being studied very actively, do leave the kid even at a problem after 4 months of birth. Maternal carriage of something called Prevotella copri is also shown to reduce the risk of IgE-mediated food allergy in the offspring. Again, data that needs to be reproduced. And higher aerobes and enterococci increase the risk of wheeze. So there is enough of this, what I would call it, microbiome studies going on, and we will have more data from something called the Orbex trial, which will be very interesting to see what happens if you actually alter these pathways. A very interesting piece of data of looking at colostrum as a protective factor against peanut allergy, a birth cohort from Australia looking at 666 infants longitudinally for the risk of developing food allergies at 12 to 18 months of age. Two groups, one was exclusively fed colostrum, the other was only partially fed colostrum. And what was found was early colostrum feeding became a primary preventive strategy for allergies prevention, for peanut allergy or food allergy prevention, and early peanut introduction, which we know and I've heard from Dr. Boyle also, is more of a risk mitigating strategy. What was found? If the babies were fed colostrum more than 5 or 6 times in a day, up to 9 times in a day, their risk of developing peanut allergy was 5 times lower, and the risk of developing multiple food allergies was 11 times lower than kids at 12 to 18 months of age. And this was very, very remarkable because these were kids who actually went through skin testing. They went through challenges for confirmation, and the data was very, very strong and very interesting. And again, those who were fed more than 9 times in the first 72 hours, 9 times a day, colostrum feeding in the first 72 hours, they had 0 allergies seen at the end of 12 to 18 months. So human milk has a lot of things in it, which I'm not going to teach a group of pediatricians. But one of the things that really makes a difference is, again, the microbiome of the baby altering, and also the passive immunity that is transferred through serum secretory IgA. There are studies going on looking at if you give mothers a high probiotic mixture and also give the infants probiotic mixture, whether you could reduce the risk of developing allergies. And there is some interesting data, but it is not uniformly reproducible, because I don't think we know all the right bacteria yet that need to be there, whether it needs to be a bacterial lysate or it needs to be these specific bacteria, but with time that has immense potential and role to play. So right from the in utero transfer to the birth mode, to the mother's health status, to the use of antibiotics, diet, infant diet, genetic risk cannot be disregarded in this whole process. So mother with atopy, higher chance of baby with atopy or asthma. But when these things are altered in the right way, they can make a huge difference for the baby. And so instead of cesarean delivery, if it is promoted to be a more of a vaginal delivery, avoiding junk foods and having more vegetables, having more fruits, having more fermented foods. Raw milk, I would not recommend because it carries its own risk with other infections. Probiotics, family size can be variable. We have a lot of people in India and still we have rising allergies. So I think the family size and crowding and exposure factor, but definitely pets, farming lifestyle, or a very interesting thing. In the very last two slides, I would like to bring your attention to a very interesting thing that has been done in India. So the first time something called Garbh Sanskar, you can call it education in the womb, was described in the Vedic texts in India was in 1500 BC. Okay. And what does this mean? You are inculcating better qualities in the infant, and you're doing this for enhancement and betterment of the fetus. And if you really look at this very carefully as pediatricians, you will realize that mothers were given a very specific diet. They were high in fermented foods. They were given a lot of vegetables, fruits. They were very well taken care of. They were given a lot of importance and attention, which improves their mental health and care. Several functions and events would be organized around them, not just like one baby shower, but ongoing events so that the mother felt cared, protected, and safe. And so her mental health was better, her diet was better, her lifestyle was better, her immunity was better. And as a result of that, what was found in all of those studies and subsequently people from our parallel sciences that they found that these kids also tend to have fewer infections, diseases, better growth, better mental health, better physical fitness. And a lot of the things that I spoke about have been influenced by a westernization of our diet and lifestyle can actually be prevented if we look more carefully at what are the things that we can actually apply from these ancient practices which were followed in India for centuries before they got lost. It would be really, really interesting and beneficial to all of us. With that, thank you very much once again, and I'll end my talk here.
Thank you, Dr. Roy. That was a fascinating and a very comprehensive insight into the prenatal factors that determine the development of allergy. And I really like the concept of Garbh Sanskar. I think, there is so much value and in our traditions, and we need to carry them forward. So thanks for reminding us about that. Thank you so much. Right. So moving on with the session. So I will be doing the next talk on feeding in the first years and talking a lot about allergen introduction. So far in our session, we have been hearing from experts about a very good overview of the development of allergy. So I will be focusing for a few minutes on the diet aspect. So I'll just do a screen share. Please bear with me. Yeah, can someone please confirm that you can see my screen?
Yes, we can.
Yeah, thank you. Right, okay, so feeding in the first years and focusing on allergen introduction. So in the next few minutes, I am going to talk about the very crucial aspects of the diet of the baby. So we've looked at the prenatal factors, and when a baby is born, one of the important things we do for the baby is feed the baby, isn't it? And so what to give, what not to give, breastfeeding, what about later, complementary feeding, when do we do that? So these are the aspects I'm going to talk about, looking at allergy development and prevention for the first 2 years of a baby's life. Okay, so what are the current recommendations for feeding? What contributes to allergy development? What is protective? Little bit about the breastfeeding issues, formula in the first days of life, and what is the role in allergy. Formula milk with breastfeeds, it's very popular these days for mothers to go for the so-called mixed feeds. Is that really harmful? In what way? What about complementary feeds? So prevalence of allergies, including food allergies, increased dramatically in the past few decades. So we've just seen some data about that. So as far as food allergies are concerned, there has been a paradigm shift from avoidance to early introduction. And a lot of confusion still remains. So I will go through some of the evidence summary. So this is a study that I really like to convey, is that the allergy epidemics. So if you look at this graph over here, so you will see that in the pre-hygiene era, allergy was much lesser. So once hygiene and its concepts took over, we found that the allergic disease rose. So if you look at the graph here, you will see that in the beginning, it was seasonal allergic rhinitis, followed by asthma several years later. And then in the late 90s, or in the 90s, let's say, there was the food allergies that started to rise. And so food allergy is actually called the second wave of the allergy epidemic. And first wave, as I said, was the inhalant allergies with asthma, allergic rhinitis, etc. And countries like Australia and some of the Western countries led this respiratory epidemic. And subsequently, the second wave of the food allergy epidemic also started. This lagged behind the first wave by a few decades. And if we look at challenge-proven IgE-mediated food allergy in a country like Australia, it affects 10% of their infants. Now, that is a very, very staggering number. It might have stabilized now, as Dr. Robert Boyle was mentioning, but we are lagging behind. We have gone through the respiratory epidemic, and if we were to go by the Western data, are we now going to face a food allergy epidemic? I think we need some more information. And also, what was found is that the new generation is less likely to outgrow their food allergy, which is extremely worrying. And why is this happening? It's because of the modern lifestyle. So changes in dietary pattern, changes in the intestinal commensal bacteria, air pollution, etc. So new studies also suggest that environmental factors can produce epigenetic changes in gene expression, which are potentially heritable across generations. And also, preliminary evidence suggests that non-Caucasian populations like us may be even more susceptible to the adverse effects of westernization from the allergy perspective, which again I find quite worrying. And this has substantial global implications because a lot of the world now is progressively urbanizing, and the developing world is moving more in that direction. And so it is unraveling these environmental drivers, which is critical so that we don't face this kind of a second wave that the West saw. Now, just to mention that the start of the food allergy epidemic, as I said, was kind of in the 90s. So in 1990, there were reports of food deaths due to peanut allergy. Before that, not as much was reported. And then they started to see a steady rise in the 90s. And then in the year 2000, the American Academy of Pediatrics Committee on Nutrition established infant feeding guidelines to see if they can counteract this rise that they saw. But unfortunately, these recommendations were not based on any conclusive studies or evidence. So what exactly was the recommendation? So they said that solid foods should not be introduced into the diet of high risk infants till 6 months of age, which means, promote exclusive breastfeeding, which is just as well. And then dairy foods should be delayed till 1 year, egg delayed until 2 years, peanuts, tree nuts, and fish delayed until 3 years of age. Now, this recommendation was not really based on any evidence, and this advice became widely followed. And unfortunately, some even follow it to date. And the prevalence of food allergy continued to rise after this recommendation. And then in 2008, they realized this is not working. The food allergy is still rising. So then what the AAP then said is that there is no support for restricting the diet of infants beyond 4 to 6 months of age as a way to protect them against developing allergies. Okay? And that is when, in the year 2008, we have the team of Professor Gideon Lack and Dr. George Dutoit, etc., who postulated that there is something that is happening where early introduction may actually be protective rather than delayed introduction. So why did they think of this? So it all started with the observation that Jewish children who lived in Israel had a very, very low incidence of peanut allergy. And this is a population that consumes a lot of peanut quite early. Whereas the same Jewish population living in the UK were found to have very high incidence of peanut allergy. So why was this difference there? The genes are the same. So clearly there is something else going on. So this led them to go on to do the LEAP study, and I'll show you some of the data. And also, just to highlight that there were other researchers who were thinking about similar lines. So this is a study published in the year 2013, where they looked at timing of infant feeding in relation to childhood asthma and other allergic diseases. Okay, and just a brief summary of what they found was that actually they analyzed data of more than 3,000 consecutively born children. This was in the US, and they found that if a mother breastfed for a longer time, there was actually a protection for non-atopic asthma, and if they breastfed for a lesser amount of time, there was a higher risk of non-atopic asthma. And the other interesting thing was that gluten and oat introduction at around, let's say, 5.5 months actually caused less asthma and allergic rhinitis, whereas other cereals like rice at less than 4.5 months, that means early introduction, actually increased the risk of atopic dermatitis. So you can see how there's a complex relationship between when a food is introduced and what food is introduced. And also they found that egg introduction, which was earlier, actually reduced asthma and allergic rhinitis and atopic sensitization. And so also they found it with fish. So the evidence was emerging. And then we have the results of the LEAP trial, which is Learning Early About Peanuts trial, which is the landmark study, which is still the landmark study, which actually guides the early introduction of allergenic foods in children, and suggesting that there is no role for delayed introduction of allergenic foods. So the conclusion of the LEAP study was that early introduction of peanuts significantly decreased the frequency of development of peanut allergy amongst children at high risk for this allergy. So essentially, they looked at children who had severe eczema or who already had egg allergy or both. That was their high risk population that they studied. So also just to mention about the EAT study, which is the Inquiring About Tolerance study, which essentially looked at the feasibility of this kind of an early introduction. In fact, they did it very early, 3 months of age, which is quite early. And what they found is actually it was achievable, and it did not affect breastfeeding, and there were no safety concerns. But they also found that food allergy prevalence was lower in early introduction group, especially for peanut and egg allergy. So now you can see how the evidence is emerging for early introduction, whereas the earlier recommendation was about delayed introduction. So there is quite a bit of paradigm shift. And this is just to sensitize you to the health nuts cohort. It's a very, very good cohort which is being studied in Australia. In fact, it is still ongoing. And periodically they bring out some data as they go. So here, this is in Australia, where they found that 10% of their infants had challenge-proven food allergy to common allergens. Now that, as we've discussed, is a very high percentage. And then when the children are 4 years old, it comes down to 3.8%. And they also found that peanut allergy was 3 times more common in infants with parents born in Eastern Asia. Whereas actually in the parents, the rate of allergic disease was much lower. And the other really important thing is that infants with eczema were 6 times more likely to have egg allergy and 11 times more likely to have peanut allergy. Now that is a very large number in terms of risk for these children who have eczema, which really means that we have to prevent and treat eczema very promptly. And the other interesting finding, which you will find in 2018 that they published, is that early exposure to cow's milk protein was associated with a reduced risk of developing CMPA. And they also found that no child who ate cashew by the time they were 12 months old actually developed cashew allergy, again supporting the role of early introduction. So so this is from Asia, and I just wanted to highlight it because it's closer to us. And early introduction of allergenic foods for the prevention of food allergy from an Asian perspective. So all of the main data that we have is from the Western world. What about here? So this is from 2017. And here, what is reported, so this was mainly from Singapore, they said that peanut allergy is much less prevalent in Asia compared to the West. And we all know that. And it's a well-known fact now. And varying patterns are there within Asia. Like, for example, what is there in Japan is very much different from what is there in India. And our diet and weaning patterns also greatly differ. So there are unique challenges in adapting these kind of early allergenic food introduction guidelines for our population. And this is also data from Singapore. And what here they have said is, again, very low food allergy prevalence as of then in Asia. And they actually looked at mothers of Chinese, Malaysian, and Indian ethnicity within Singapore. And they also found that in this population, early introduction of allergenic foods may not be necessary in populations where overall food allergy prevalence is low. Okay, so what this tells us is that infant feeding recommendations should be carefully tailored to the individual population. So we cannot just interpret the Western data for our population. And certainly we in India, we need more data. What about the situation in India? Actually, Dr. Robert Boyle also showed us some of the data. And this is actually data in older children, but this is just to show you that the prevalence of food-specific IgE sensitization was 19% in India, but the prevalence of food allergy was very low, 0.14%. Now, this is from a few years ago only. And here, in fact, you will see that in this population studied, peanut sensitization was 6%, but peanut allergy was extremely low, 0.03%. And this is, again, to give you a summary of the ERK guidelines for the prevention and development of food allergy in infants and young children. This is the 2020 update. So, quite a latest update also. So here, what they have suggested is that avoid the use of regular cow's milk formula as supplementary feed for breastfed infants in the first week of life. Now, I think this is something that we really need to think about and follow if possible. What we find that it is fairly common practice in the first few days of life that a baby is introduced to formula while the mother is establishing breastfeeding. Now, we have seen from what Dr. Sitesh Roy showed that colostrum is actually so protective for the prevention of allergies. So we just need to feed these baby colostrum and not really resort to cow's milk formula. And wherever possible, there's always going to be exceptions, but in the vast majority of babies, this is going to be possible. And in the ERK guidelines, they've also mentioned about introducing well-cooked egg in the infant diet as a part of complementary feeding. And of course, more recommendations about early introduction of peanuts. And also off note, we heard Dr. Robert Boyle also speak about this. There is no recommendation for use of prebiotics, probiotics, supplements, hydrolyzed infant formula, etc., in the prevention of allergy in these infants. So just a couple more slides. So this is again data from US. So consensus approach to the primary prevention of food allergy. Essentially, it highlights similar points. Eczema is simply the highest risk factor for IgE-mediated food allergy. And we just heard from Dr. Sitesh Roy how eczema is increasing in our country. And we need to be very prompt about identifying and treating these babies. And no specific association of exclusive breastfeeding and primary prevention of food allergy. This does not mean that we do not advocate breastfeeding. Of course we do, and we do it for as long as possible. But here in their study, they have not found any conclusive evidence for prevention of allergy in particular. We all know about the various benefits of breastfeeding, exclusive breastfeeding even, and we need to promote that as pediatricians. And the other interesting thing that I found here was the screening before the introduction of allergenic foods, even in high-risk babies, was not necessary, provided you introduce before 6 months. So this is a very important message from this particular practice parameter. And I think in the interest of time, I'll just skip through this. This is just to show you that there are 28 different feeding guidelines, infant feeding guidelines for allergy prevention from all over the world. So that's quite a few. And yeah, just to show you association between duration of breastfeeding and childhood asthma outcomes. This is again from 2022. We find that duration of any breastfeeding had protective linear trend with asthma, but not really other outcomes. And duration of exclusive breastfeeding and childhood asthma outcomes, there was a dose-dependent protective association. So all the more reason here, based on this study, for us to promote exclusive breastfeeding. And just as a secondary outcome, they found that children born by vaginal delivery had less allergy compared to children born by cesarean delivery. Again, this has been covered, so I will skip it just to highlight that there is emerging evidence that irregular cow's milk exposure might actually increase the risk of cow's milk allergy. So that means infrequent formula supplementation here and there should definitely be discouraged. Okay. And regarding the role of eczema, Dr. Sunila Nayak will talk to us in detail. But the idea I want to convey is that the gut is a tolerogenic organ. The skin is a sensitizing organ. So we need to introduce the allergens to our babies before skin sensitization can occur. So we have to use the tolerogenic potential of the oral exposure or the gut exposure. And a quick word about baby foods. We all know it's becoming very popular even in our country. And here we have in 2024 this publication that says that ultra-processed foods have an adverse outcome. So commercial baby food intake was associated with childhood food allergy. And exposure to ultra-processed foods was associated with increased occurrence of other allergic diseases like asthma, wheezing, food allergies in an atopic dermatitis and allergic rhinitis. But we do need more studies, and that's ongoing. So just to again highlight the IAP action plan. Now, I cannot emphasize about this more. So this is about the complementary feeding for infants beyond 6 months of age. So as we all know, IAP recommends exclusive breastfeeding for all infants till 6 months of age, and then a beautiful guideline about using homemade food for babies and discouraging commercially available foods for use for our babies. So give them what forms a part of your home diet in the right form, in the form appropriate for that age, and we will be doing them a big favor. So this is just to show you, this is from very recent, a couple of months ago. It shows that the guidelines for early food introduction is actually working. So incidence and risk of development of peanut IgE mediated and any other IgE mediated food allergy is actually decreased significantly from the pre-guideline to the post-guideline period. So early introduction definitely works, and they have seen the results. So in conclusion, exclusive breastfeeding for 6 months, regional and traditional complementary feeding patterns, a variety of food. No need to delay introduction of allergenic foods like we did in the past. And identify high-risk infants with eczema, diagnosed with other food allergy, strong family history. These infants will be addressed a little bit differently. And need for India-specific recommendations in infant feeding for the at-risk babies at risk of allergy. Thank you very much for your kind attention, and I will stop my screen share now. So I will now hand over to Dr. Vivekanand for the next talk on the role of environmental factors in allergy and allergy prevention. So Dr. Vivekanand, welcome. And Dr. Vivekanand is a pediatric pulmonologist practicing in Chennai. He's also allergy trained, and he's also a sleep medicine specialist working at Rainbow Children's Hospital and VVV Allergy Pulmonology Center. Over to you, Dr. Vivekanand.
Uh, and also, I would like to thank IIP Central Allergy team, Dr. Nandana and Dr. Neeraj Gupta for giving me this opportunity. Shall I share my slides?
Yes, please.
Yeah. My slides are visible.
Not yet, Dr. Vivekanand. Now it is. Now it
Yeah.
is.
So, over the next 15 minutes, what I would do is I would give a brief overview of environmental prevention in infancy and early childhood. My main overview of my talk will be what to target, why it matters, and what to advise. And I will lay down some evidence-based strategies for disease prevention, particularly from a general pediatric point of view, and what to advise parents. So, why early intervention matters? Because infancy is a very critical window for lung programming and development. Mainly because the first 1,000 days of life from late pregnancy through early childhood is the stage of lung development. Mainly alveolarization takes place continuously. Airway caliber grows in size. There is vascular growth continuing postnatally. And immune programming in early life exposure shapes the balance between tolerance and inflammation, influencing the risk of allergies in older childhood or in early childhood. Most importantly, there is epigenetic effects. Environmental factors can alter gene expression without changing the DNA sequence, leading to long-term cardiorespiratory consequences. This is the period of a window of vulnerability, and that is the opportunity of for prevention which exists. And the key clinical implication is that preventive counseling in infancy is not optional; it is a powerful disease-modifying intervention. So the what matters is the biggest modifiable wins in routine practice are tobacco nicotine exposure elimination, cleaner air, indoor plus outdoor, damp mold control and toxin avoidance with particular emphasis on lead chemicals and pesticides. Now, there was a statement in October 2024, the WHO, that household air pollution contributes to about 3.2 million deaths per year in 2020, including over 237,000 deaths of children under the age of 5, which is a very staggering amount. So, my big 10, which I will go through over the next 10 minutes, will be smoke and air, dampness and indoor molds, how to prevent lead and toxic environmental exposure, allergens and chemicals, and safe feeding and water, pesticides, outdoor air pollution, a small note on plastics and microplastics, which we often forget, which I particularly forget, allergen strategies, and some final conclusion on infection prevention and nutrition. Now, moving on to smoke and air, there is obviously there is an old paper in 2023. So it is no proven beyond doubt that there is strong links to wheeze, asthma, bronchiolitis, otitis media, and SIDS risk and long-term cardiometabolic harm because smoke residues persist on clones, furniture, and car seats. Leave alone second-hand smoke. These are all called what is known as third-hand smoke. AAP emphasizes screening and counseling in pediatric care and household smoke, particularly biomass exposure, major global driver of childhood pneumonia and chronic respiratory morbidity. My practical advice for a general pediatric population would be complete smoke and vape free home and car policy. Avoid smoking on balconies, kitchen, or near windows. We have to request parents to change clothes and wash hands after smoking outside. Prefer LPG, electric, or induction cooking. Use always a chimney or exhaust fans with vented outdoors. Keep infants out of kitchen, which is very common practice in rural areas during cooking. Avoid burning incense, camphor, mosquito coils indoors, which is very prevalent. Avoid scented sprays and plug-in air fresheners. Moving on to indoor dampness and mold. There is this nice guidelines published in January 2020, and there is proven beyond doubt that it is consistently associated with cough, wheeze, and asthma development. It is a marker of actual poor housing quality, and source control and remediation are key interventions. Clinical improvement has been seen after mold removal. So whenever there is ongoing mold exposure, the fungal spores are inhaled. Therefore, what happens is the mycotoxins which are present in the fungal spores cause a disrupted airway epithelial barrier. The dendritic cells are becomes less sensitized. Therefore, there is reduced interleukin 12 production, leading on to inflammasome activation and oxidative stress. And what happens is these fungal spores also have some particles called beta glucans and chitin, which promotes immunomodulation and ongoing airway inflammation, which leads to persistent airway inflammation, and we are prone for even non-allergic asthma. Practical advice for moles will be fix leaks fast and therefore keep indoor humidity moderate. Ensure sunlight and airflow. Clean small moles safely and for large areas. Involve building maintenance team and source removal is always a key. This is from 2025 EACI guidelines on environmental science for allergy and asthma. Moving on to toxins, neurodevelopmental toxins which cause systemic harms. Lead prevention, particularly old paint, dust, and some cookware, ceramics, toys, jewelry, and contaminated soil and water is very important. Primary prevention and testing were indicated. So this is a very good picture from CDC 2024. That is homes which shows the impact of lead involvement. Homes built before 1978, where lead-based paints were banned, probably contained lead-based paints. When the paint peels and cracks, it makes lead dust. Children can be poisoned when they swallow or breathe in lead dust, and certain water pipes may contain lead. Lead can be found in some products such as toys and toy jewelry. Lead is sometimes in candies imported from other countries or home remedies traditionally used in rural areas. And occupational hazards more from an adult perspective view. So important considerations for lead as lead can be found in many places in children's environment. There is no safe blood level as per CDC. Even low levels of lead in blood can be harmful, and the CDC and AIP recommendations use 3.5 microgram per DL as a reference value, prompting action and exposure mitigation. Now, this is from JAMA 2025, Early Life Low Lead Levels and Academic Achievement in Childhood and Adolescence. Practical measures are avoid peeling paint and renovation dust, wet floor mops and wash toys regularly, ensure hand hygiene before meals, risk-based screening and blood lead testing were indicated, and nutritional optimization because iron and calcium levels which are maintained adequately can can eliminate their absorption. Moving on to safe feeding and water. Reduce heavy metal dietary exposure sensibly with varied diet and avoid suspect products. Follow public health advisories and lead has no safe level. Safe or appropriate filtration and boiling practices as locally recommended and hygienic complementary feeding. Moving on to pesticides in home and food, there is a specific mention on AAP 2020 guidelines on heightens vulnerability in pregnancy, early childhood, and recommends minimizing exposure. The advice is generally to prefer integrated pest management, seal cracks, remove food sources, traps, baits over space, never spray when children are present, follow re-entry times strictly, wash produce well, peel when appropriate, and avoid storing pesticides near food. Moving on to outdoor air pollution with particulate matter 2.5 and NO2. Early life exposure is consistently associated with respiratory morbidity and asthma risk. This JAMA publication in 2024, the general advice was to check local air quality index on poor air days, reduce outdoor exertion during this time for children, keep windows closed during peak traffic, then consider indoor play for children during these hours. Avoid stroller walks along heavy traffic, pick inner roads and green routes if there are any. If using air purifiers, prioritize bedrooms, nurseries, and continuous use during high air quality index days. Now, moving on to plastics and microplastics, there is some emerging evidence that was taken from the Life Journal in 2024. These are all the microplastics, PVC, PS, PLA, PMMA, and so on. Plastic toys, baby bottles, and crawling hand-to-mouth activities leads to exposure in children, and the detection is mainly through in breast milk, infant formula, and infant feces. The practical advice for microplastics would be recent reviews highlight potential infant exposure sources including bottles, formula preparation, and toys. Avoid microwaving or boiling food in plastic. For formula preparation, minimize high heat shaking in plastic. Consider glass and steel for mixing when feasible and then transfer. Prefer BPA free and minimize soft plastics. Choose silicone, steel, glass wherever it is practicable and applicable. Moving on to allergen sensitization, where it is in alignment with evidence base, the practical advice, particularly for pets and house dust mite, which is the most common allergens, are control dust mite allergen when clinically relevant. symptomatic eczema and asthma and allergic rhinitis, wash bedding hot, high temperature washing more than 65 degrees, and reduce stuffed toys in bed and manage humidity. With regards to pets, individualization is important and avoid drastic pet removal unless clear sensitization is documented with reproduction on symptoms. Moving on to the last few slides on infection prevention. Hand hygiene and respiratory etiquette in household members is very important. When you reduce crowding around young infants during peak viral season, mass symptom screening for visitors when a newborn is at home. Ventilation indoors, fresh air beats, therefore close roof with many people results in a more vulnerable population for the infants. These environmental strategies pair extremely well with immunization strategies and RSV protection policies where applicable, particularly in infancy and the early neonatal period. Moving on to nutrition and microbiome, we encourage breastfeeding whenever it's possible with because of the immune and respiratory benefits. Avoid unnecessary antibiotics and acid suppressants in infancy due to microbiome effects. Diverse minimally processed complementary feeding and adequate vitamin D and iron as per local standardized guidelines and protocols, and reducing ultra processed foods, sugary beverages, and it helps in reducing long term metabolic and inflammatory risk. This I have never done it routinely in practice, but over the last probably a year or so, is gaining more importance, and I have particularly attributed to gaining more importance is a practical environmental history, which is probably a 60-second checklist which you can provide to parents. Air and smoke. Anyone smokes, vapes at home, car, visitors, or caregivers. Cooking fuel type, kitchen ventilation, chimney, and exhaust. Questions. Incense, dhoop, mosquito coils, indoor pesticides, and fogging. With regards to home environment, dampness, mold, condensations, recent flooding or leaks should always be asked. Pets, cockroaches, rodents, mattresses, age, and stuffed toys should always be mandatory question when dealing with children with allergies. Toxins, age of the house, the renovation, peeling paints, hobby, occupational exposures in family, imported cosmetics, spices, ceramics, and toys, and possible lead sources are very important. And water source storage and any known contamination issues in the apartment or in the residential area is particularly important. Outdoor, always inquire about the roadside residence, school near traffic, any construction which is nearby, and typical commute time in the traffic when the infant or the young child is being carried to school or the daycare. My key take home messages will be environmental prevention starts before disease onset. Early life interventions have lifelong benefits. Pediatricians play a crucial advocacy role in demonstrating the effects to parents. Environmental prevention is a cost effective, high impact strategy with this emphasis on this particular 10 to reduce childhood morbidity and improving long term health outcomes. It's simple, consistent counseling with a 60-second questionnaire can make a substantial difference. A small environmental change in early life can prevent chronic respiratory disease later. These are my references, and I would like to thank one and all for the opportunity.
Thank you. Thank you, Dr. Vivekanand.
Thank
That
you.
was so beautifully portrayed, and very practical points that you brought out. And I really liked your checklist at the end. So thank you for that. I think that will be very useful for all of us in practice, because for us as allergists, the environmental history is so crucial, isn't it? So thank you very much. Yeah.
Thank you.
So next we will have a talk on skin barrier and its effect on allergy. Now this will be done by Dr. Sunila Nayak, who is a senior pediatrician and allergy asthma specialist based in Bangalore. She's a consultant at Nayak Clinic, Rainbow Children's Hospital, and Cloud9 Hospital. She's trained and worked in the UK for 17 years, and she's a teacher par excellence and faculty of several allergy courses and conferences. Over to you, Dr. Sunila.
Thank you, Dr. Nandana and IAP Central IAP as well as IAP Allergy Chapter for asking me to speak today and be part of this wonderful webinar. I have really enjoyed the talk so far. And let me just share my screen here. Can you see my screen?
Yes.
So Since it's been going so wonderfully well, let me not interrupt the flow. We will just now go on to the next part of allergy prevention and looking at allergies in general, which is the skin. It is, the skin is possibly the largest immunological organ that you have. Essentially, if you not just looking at it as a flat surface, if you look at all its appendages, its nooks and crevices, it has a very large surface area where which is in direct contact with the external environment right from the day you're born. So possibly the place where you can have the maximum interaction with the environment. But it is not the same. The skin is competent in a baby, especially a term baby. When the baby is born, the skin is competent, but it tends to mature in the first few years. So it does change. It's not the same as you would see in an adult or an older child. So what are the basic differences or the main differences that you would see in skin? What you would see is, you see a thinner stratum corneum. The corneocytes are much smaller. There is much less what they call the natural moisturizing factor. And because there are much less lipid as well, which is not shown here, there is also a much more easier it's a thinner, so more transepidermal water loss occurs in an infant skin. With all this, you can imagine they are far more vulnerable, far more susceptible, and also far more sensitive to any insults that they come across. And they're born into, sorry, it's not moving. Yeah. So we all know, and we've known for a long time, that a skin barrier compromise seems to herald what we call the atopic march. It leads and can lead to potentially early onset atopic dermatitis and other chronic inflammatory skin conditions. It can lead to any of the other allergies later on in life, like food allergy, respiratory allergies, and so on and so forth. But it all seems to begin with the skin. There are also several studies that support this, and especially there are a lot of studies which looked at food allergy and atopic dermatitis. The ALSPAC study looked at a single oozing, crusting skin rash in a very young child. It looked as, and it appeared to be an independent risk factor for development of peanut allergy. In health nut studies, early severe onset of atopic dermatitis increased more than 50% the chance of a challenge-proven food allergy. In the LEAP study, they looked at it in a different way, where they looked at the dose. So there was a dose-dependent increase in the food sensitization based on increasing the severity of atopic dermatitis based on the SCORAD levels. And also, it seems to be that the longer you have infantile atopic dermatitis, the higher your chance of developing a food allergy. Also, there is good evidence to show that if you delay treatment of what is obviously inflamed skin of an atopic dermatitis by delaying the enhanced treatment, then the chances of you developing other allergies increase quite considerably. So everything shows that the atopic dermatitis does have a role to play in other allergies. The recent study in Singapore looked at trajectories of atopic dermatitis. We know that not all children with atopic dermatitis are the same. Some have early onset and they get better. Some have early onset, they are severe and they persist. And some don't even have any issues in the first year of life, but they start early on in the second year. So why? And this is what they had studied, and they looked and they found that there were three distinct trajectories. One where as I said, early onset which is a little bit transient. So it is severe in the early part of your life, then seems to get better. This was found to have a much more in boys with a family history of atopy. And they went on to have sensitization with dust mites and maybe aero allergies later on in life. And also, things like asthma. The second part, where it was early onset but quite severe and was also persistent, seemed to have more close link with food allergies. Again, went on to have some aero allergies also later in life. But interestingly, these children also had a higher association with maternal, antenatal, or intrapartum antibiotic use. Then there was the group which started out a little bit late, but went on to have, a not very severe, but a persistent atopic dermatitis. And these are the ones who seem to have quite a number of other allergic comorbidities. So why is the first 1,000 days so critical? We know that the skin barrier, the immune system, and the microbiome are all developing and maturing together. So there is a high level of plasticity at this age, and this is the time when if you do a good intervention, then you might actually change the course of this disease, decrease the chances of further allergies or severe allergies. And that is why we really would like to see what sort of interventions we can do at this point. And also early exposures we know do shape long-term inflammatory risk. So this is the time we need to be particularly aware and looking at what is going on and see where we can help. We know atopic dermatitis is a very complex condition. It's not all, you get exposed to something, you get sensitized, and you get in a very specific manner. It is a complex gene environment interaction wherein the genetics are in the form of atopic family. They can have skin barrier defects, whether it is a filaggrin gene, a sphinx gene, or so on and so forth. Epigenetics based on what the maternal exposure has been, whether during pregnancy, whether she's atopic or not, and what happened during the prenatal, perinatal, and the immediate postnatal period. That also can affect the epigenetics, whether then you come to the environment itself, as we had a lovely talk just now, and there you can see whether the allergens, whether they are transcutaneous or inhaled, food or aeroallergens, the exposure to them. More importantly, the microbiome, which is, whether the skin or the gut, what is it exposed to? What sort of bugs are residing on the skin or in the gut? Pollutants, irritants, we've heard about all of them in the last hour and a half to two, and we've had some wonderful lectures about it. So I'm not going to spend more time on that. But essentially, it is a interaction between the genetics, environment, and depending on each different sort of scenario for each child, it is a context dependent manner in which the skin responds. And that immune response is dependent on many of these and in what sort of timing they have been exposed to it. With the skin, there are two aspects to it. One is what they call the outside in, which is where the epithelial barrier has abnormalities, and that leads to immunological abnormalities. Or the inside out, where their child is already known to be a high risk for Th2 pathway or atopic, and hence the immunological abnormalities skew the responses to epithelial barrier and lead to problems in barrier integrity. Now, both of these happen very early on in infancy, and it is very difficult to tease out which happens first and which happens later, or what led to what. But the important thing to remember is the skin barrier is crucial and critical. It can be a skin barrier issue based on just mechanical, something like scratching. It could be the allergens around you, which are actually, entering through these barrier defects. It could be the exposure to the wrong kind of microorganism or pollution or stress, which leads to Th2 skewing. This is all there. But what are the things that are innate, which are difficult to change? Things which are genetic, which are difficult to change, but have been associated with impaired skin barrier. And we see that the one gene that has been studied the most amongst this is the filaggrin gene. And a null mutation of the filaggrin gene is associated with the impaired skin barrier impaired skin barrier. And we see that these people who have filaggrin null mutation have a much higher risk of food allergies, as well as a much higher chance of severe reactions like anaphylaxis with food allergy. This has also been noted where the skin looks completely fine, but the person has a filaggrin null mutation and goes on to develop food allergy. So it is independent of the atopic dermatitis status that if you have filaggrin gene, you are much higher risk of developing a food allergy. That brings us to another question. Is atopic dermatitis only what we see? That is clinical atopic dermatitis, where we have all of the clinical signs and symptoms of atopic dermatitis. A recent study looked at children who were at risk of developing atopy And they took their skin tape strippings and looked at the stratum corneum and the skin itself. And they found that in the children who did not have any clinical symptoms or signs of atopic dermatitis, but were known to be at high risk, they did have the similar markers and those children who had actual infantile atopic dermatitis. It was only that the markers were more exaggerated and obvious in the clinically symptomatic children versus those who were preclinical. So they had lower natural moisturizing factor. Their ceramide-free fatty acid base alterations were quite significant. And they also had microbiome alterations. What colonized their skin was quite different and similar to people who had clinical atopic dermatitis versus those who didn't. So there was a significant Th2 skewing in this group of children. Also, the other hypothesis which has been around and now has been quite substantiated is what we call the dual allergen hypothesis. This we've already heard about by Dr. Sitesh Roy already. And essentially what it says here is if you're exposed to a food allergen via your skin before you have ingested it, so you're not yet exposed to it orally, but you are exposed to it through the skin, then your likelihood of developing an allergy is much higher. And conversely, if you are exposed to the food orally or you ingest it before you get exposed to it via the skin, then you develop tolerance. This is a very important study and a very important finding. And we have to keep this in mind because it gives us a lot of room for intervention and advice to potential patients and parents. One study which substantiated it even further is where they looked at the amount of peanut protein present in the house dust of a baby at the time of birth. So here we are not talking about any edible food or edible substance being applied to the skin of the baby or being given it to eat. It is essentially, it's born in a house where somebody else is eating the allergenic food. So there is that substance within the house dust of that particular house. So they showed that for every unit increase in the amount of peanut protein in the house, the chance of the child becoming sensitized by school age is 3% and becoming allergic by school age, sensitized is 6% and becoming allergic by school age is 3%. So there is a clear indicator that there is some sort of a link, even when there is no actual application, but that is the food allergen is in the air, or the air allergen is in the air. Not just food protein, we also have other things in around a newborn baby. As soon as the baby is born, they come into a cloth, or they're received in a cloth which may have been there may be detergents that have been used in the cloth that may rub off on the baby's skin. High pH creams, we need an acid mantle which the baby doesn't have at birth and takes time to develop, and high pH creams will again insult the epithelial barrier and increase the permeability of these babies. Detergent, I forgot to say, have surfactants, which are essentially emulsify lipids. So again, will affect the lipid barrier in the baby's skin. Genetic factors we've just spoken about. Other than that, the microbiome itself, being born maybe in a sterile operating theater, you are exposed to a much different variety of bugs versus, say, having had a vaginal delivery and being born either at home or in a normal delivery room. Of course, food allergens we just talked about. So essentially, what are we trying to do? We are trying to identify early and advise appropriately. So whether it is the prenatal things where you look for maternal atopy, advise about stress and antibiotics, whether it is the natal where you would like to avoid C-section and prefer a vaginal delivery and encourage breastfeeding, and also talk about early skin care and effects about the transepithelial water loss. In the postnatal, which is possibly the place where most of us pediatricians will be having a much better say, it is extremely important to advise about gentle newborn skin care. They don't need to be bathed every day when they're born. They need to have their vernix covering their skin for as long as they can because it is very protective. The earlier you recognize and start targeted emollient treatment, the better it is. And also early weaning, as Dr. Nandana has just talked about, with the right allergenic food being introduced early as soon as the child has started weaning, rather than avoiding it and trying to keep it for later. So what is the thing that we can do? We can educate the parents or the parents to be. And together, we would want to plan appropriate steps such that the child actually, you actually make a difference in the progress of that child's atopic march or allergies in themselves. We have actually spoken a lot about environment and other things already, so I'm not going to go into that in much more detail. I'm going to focus on the actual skincare aspect itself. And the backbone of all skincare in allergic atopic dermatitis or eczema is emollient. Emollient is absolutely important and should always be used even when there is no sign of a flare-up or inflamed skin. So even when the atopic eczema appears clear, you would want and you would advise them to use emollients, and you use it in large quantity. It needs to be bland, unperfumed kind of a emollient. So far, there are several studies, but there is no one emollient which stands up and says this is the best and that needs to be used. It can be any kind of emollient as long as it has none of the substances that are bad for your skin. So it can be increased or decreased based on the need and response, and this also needs to be taught to the parents. The other very important thing is bathing. In India, we have a very strong tradition of massage and baby massage I'm talking about, which is before bath, after bath, many times. And there are different things that people use to massage the baby's skin with. The one that has been used traditionally and has been quite, seems to be quite okay is coconut oil. But there are a lot of other substances, quite often edible substances, which have been applied on the baby's skin and quite often possibly have led to sensitization. This is especially important to remember and advise when the child is at high risk of atopy as well as has any inflamed skin. If you see any inflamed skin at all, then really advise against using anything edible, either in the oil or as its own, the food itself, or even as part of the cream that is being used to apply for the emollient. Things like oats or coconut oil in the cream also can sometimes lead to sensitization if it is used on the wrong type of skin at the wrong time. The other thing that you have to remember is the cleansers like soaps or, whether, it's the body washes. Most of these also contain surfactants. As I was saying, surfactants emulsify the lipids. They don't only emulsify the lipids of the dirt and everything that they are trying to take away, they also damage the substratum corneum lipids and hence increase the skin permeability, skin irritation, and hence damage the epithelial barrier. So you would really want to advise them to use as little cleanser as possible and only where it is absolutely necessary, rather than using tons of cleansers all over the body and using a very hot wash, which will take away all the child's own oils too. So the other thing which has not been mentioned here is that it should be a short bath, which is not very hot water, lukewarm water. And skincare, of course. We have already talked about the emollient, and there is a lot of corticophobia amongst both the doctors and parents. This needs to be addressed with the correct sort of advice, because you don't want them to use too much, but you don't want them to be scared and not use it at all, because the more time the skin is inflamed, the higher chance of the allergies getting worse and more sensitization to new things. Hydrating, occlusive dressings, bathing process, and antihistamines are all important parts of the skincare, because even something mechanical like scratching will again affect the epithelial barrier and lead to further worsening of the skin. There are a lot of adjuvant therapies, and it is outside the remit of this talk to go into that. But as you can see, they're all in addition to what is the backbone of treatment, which is emollients. Of the studies that we have seen, there are some gaps, and it would be wonderful if more studies were done in these areas, and it would be really helpful to the parents and us doctors to advise these parents. Stratified prevention, and what are the steps to take to prevent in high risk infants? What can we do? And what are a milder risk, what is a higher risk, those kind of things we don't really have much information on. Also, as I said, there is no perfect emollient cream that has been sort of studied so far. Everything has its pluses and minuses, and it ends up being a lot of trial and error for each child. So it would be nice to have some optimal emollient formulations, and hopefully we will have those. Also, to recognize which child early on before the clinical, as Dr. Vivekanand was saying, it's all about prevention, prevention, and prevention. But for this, if we have something that we can use to recognize those children who are at the highest risk, a biomarker which is validated, would be really useful. And prenatal intervention trials would also be wonderful, especially in those children where we have a very strong family history of atopy, and we know that the child is going to be at a high risk of allergic tendencies. So the recommendations for the skin: optimize maternal health, avoid unnecessary antibiotics for mom and baby, support vaginal delivery wherever possible, and encourage breastfeeding. Newborn skincare should be gentle with targeted emollients early, recognize and treat eczema appropriately. Thank you.
Thank you. Thank you so much, Dr. Sunila, for that really beautiful overview of eczema and how it affects allergy development in the baby. And you also covered some aspects of the treatment and why that is important. So thank you so much. So with that, it brings us to the end of this webinar, where we had a comprehensive overview of early childhood development of allergy, as well as in pregnancy. And then we also saw the role of diet, the role of environment, and the role of skin, very, very important in the development of allergy and its prevention. With that, I would like to thank all our speakers for today for your valuable contribution. Dr. Neeraj, over to you, please.
Thank you, ma'am. I think this was wonderful webinar, and I was looking very carefully and listening very carefully. The concept when it came like 1,000 days. So I was just imagining and thinking that we can probably build something around, but I was never thinking, I never thought that there will be so much things which we can actually discuss, and we can probably come out with so many messages, different messages, right from the food to the environment and to the skin and so many other things. So I think this was really good. And I would like to request Dr. Singarvelu sir, if sir is around, that if he can probably plan something, some ideas like IAP has planned for some initial 1,000 days for nutrition. So if he can probably plan something which is revolving around allergy prevention, because this will be next uh, big disease which is going to come up, that if we can execute something for the initial 1,000 days to prevent and to probably you can say like reduce the burden by somehow, so that will be great. So but I think wonderful moderation, ma'am, and all the speakers are excellent. Everything was really really very wonderful. Thank you so much.